name's Steph. I'm an F1 working at St George's Hospital. This is a short video on subarachnoid hemorrhage, which is a useful topic for those of you that will be working in AMU, A&E, Gen Med or Neuro, as you'll see lots of suspected cases. Subarachnoid hemorrhage classically presents as a thunderclap headache with a very sudden onset. The key thing to help distinguish it from other types of headaches is that it reaches its maximum intensity within seconds. It's often described as feeling as though they've been hit over the back of the head, and the pain is very severe, often described as the worst pain they've ever had. They can also get symptoms from irritation to the meninges, such as photophobia, neck stiffness, nausea and vomiting, but this is non-specific. Around half of people who have a subarachnoid hemorrhage present in a coma or dead. There may be a history of trauma, or it can be a spontaneous bleed from an aneurysm, which is the most common cause, or from an arteriovenous malformation or rare disorder. In about 15% of cases, the cause of the bleed is never found. So how is it diagnosed? The first line investigation is a CT head, looking for fresh blood which shows up as a whiter area on a CT scan. As you'd expect for a subarachnoid hemorrhage, which is a bleed under the very thin arachnoid layer directly around the brain itself, under the dura, the subarachnoid hemorrhage shows up particularly in the sulci, which are the grooves on the brain's surface, in the basal cisterns, and sometimes in the ventricles, as in this CT here. Although a subarachnoid hemorrhage won't show up on CT in as many as 7% of cases, you always have to do a CT first to check for any intracranial tumour or mass effect. If there is, a lumbar puncture is contraindicated due to the risk of causing coning. If the CT is negative, the next test is a lumbar puncture looking for xanthochromia, which comes from Greek meaning yellow colour, as shown in this picture. Xanthochromia is caused by the presence of bilirubin in the CSF from the breakdown of red blood cells, and it takes around 12 hours to form. The reason you don't look for fresh blood is because this could just be from the lumbar puncture procedure itself and not from a hemorrhage. The management is supportive. As with any acutely unwell patient, start with an A2E assessment to address any immediate issues, and if they're conscious, offer antiemetics and analgesia if needed. You need to refer to neurosurgery for further management, which could include doing a CT angiogram to look for a brain aneurysm or arteriovenous malformation that could be coiled or clipped to prevent further bleeds, or for ventricular drainage in patients with hydrocephalus. Oral nimodipine should be given to reduce the risk of vasospasm, which is a common complication around 5 to 10 days after a subarachnoid hemorrhage and causes delayed cerebral ischemia in these patients. So to sum up, we've spoken about the presentation of subarachnoid hemorrhage, which can be as a sudden, severe occipital headache, possibly with signs of meningism, or with coma or death. The diagnosis, which is a CT scan first line, and if that's negative, a lumbar puncture, if it's not contraindicated, to look for xanthochromia. And also the management, which is supportive. Do your A2E assessment, give oral nimodipine, and refer to neurosurgeons. So here are some references if you want to find out more. The Geeky Medics page on subarachnoid hemorrhage includes some detail on what to look for in your A2E assessment in subarachnoid hemorrhage. And the Radiopedia website is great for practice looking at CT scans with explanations. So that's it.